Can I start?
Wait, Dr.
Yes.
Akshay.
Yes,
Wait.
sir.
Please stop share. Please stop.
Stop sharing the screen. Let me express my sincere thanks to the Cardiological Society of India, the President Dr. Vijay Bang and Dr. Dayasagar Rao, one of our senior eminent cardiologists, for giving us the opportunity to get involved with the CSI Masterclass. And it's a pleasure and privilege to have a academic session uh, without any conflicts of interest or bias, purely related to the science that we present. I'm very glad that I have with me the team from our MGM Medical College in Navi Mumbai, Professor Dr. Shilpa Deshmukh Kadam. He is the professor of cardiology and pediatric cardiology at the hospital and the medical school. And also Dr. Brian Pinto will join us in a while. He is the professor and in charge of the cardiology program at the Holy Family Hospital in Bandra, West Mumbai. Dr. Akshay Dafal is the DM resident in the Department of Cardiology at MGM Kamote. And I am Dr. Uday Jadhav. I work with the Cardiac City and Cardiac Department at the MGM New Bombay Hospital, and with primary interest in all sorts of cardiac imaging. With these few words, thank you. And Dr. Akshay Dafal, if you can take your presentation and cases forward. After that,
Yes.
I will make a request that Professor Dr. Shilpa Kadam can do a presentations. I will speak briefly, time permitting, and we can have discussion. Thank you very much. Dr. Akshay Dafal, please.
Yes, sir. I will begin, sir. Good morning, one and all. Myself, Dr. Akshay, resident of Cardiology Department from MGM Kamote. I will be talking on the topic coronary angiography in post-CABG patients. We will be discussing few cases. Case number 1, a 54-year-old male who is a known case of type 2 diabetes mellitus, CKD or maintenance hemodialysis, with a past history of CABG with 2 grafts placed in from SPG to diagonal 1 PDA and Lima to LED in 2016. Patient presented with complaint of difficulty in breathing and chest pain since 3 months. Difficulty in breathing was initially NYHA class 1. That is, patient could walk for around 200 to 300 meters to his work, could climb 2 to 3 floors, and over the period of 3 months, the dyspnea has progressed to NYHA class 3. There is marked limitation of physical activity with a recent worsening of dyspnea at rest in the last 3 days. That is NYHA class 4. It is associated with orthopnea and PND. Second complaint was chest pain. Chest pain was retrosternal, burning in character, non-radiating, aggravated on performing strenuous activity, and was lasting for 3 to 4 minutes, relieved at rest or taking medications. During hospital stay, patient was optimized with anti-failure medication and was planned for coronary angiography. On general physical examination, the positive findings were patient was restless, lying propped up in bed. Pulse was 110 beats per minute, regular, low volume, weak and thready pulse. Blood pressure was 140 by 90 millimeter of mercury in right arm. Respiratory rate was 26 cycles per minute, abdominothoracic. Saturation was 96% on 4 liters per minute. JVP was elevated 4 centimeter above the sternal notch. Pedal edema was present, bilateral pitting up to the shin of tibia. Systemic examination relevant findings were S1 soft, S2 normal, S3 gallop heard, no murmur, no other abnormal heart sounds. Respiratory system findings was bilateral fine inspiratory crepitations were present at inframammary, axillary, and infrascapular region on left, axillary region on right, with absent breath sound in right posterior scapular line below 5th intercostal space. Other systems were normal. His investigations were the biomarkers were raised. CPKMB 167 units per liter, HS troponin is 658 and 2624 nanogram per deciliter, the consecutive samples. Anti-Pro BNP was 3245 picogram per ml. Hemoglobin was 9.1 milligram gram per deciliter, and serum creatinine was 2.89 milligram per deciliter. His ECG was done. ECG was suggestive of poor RWA progression with T-wave inversions and ST elevation in V1 to V4. It was suggestive of old anterior wall MI. 2D echo was done. This is parasternal long axis view, and this is parasternal short axis view. In parasternal short axis view, we can see hypokinesia of anterior, anteroseptal, and anterolateral segment, and apical segment as well, with a LVEF of approximately 25%. Apical four-chamber view. Apical four-chamber view showed hypokinesia of apicoseptum, apicolateral, and mid antero-inferior anterolateral segment. Coronary angiography was done. In coronary angiography, we can see the native or native coronaries. We can see the LCX is small and non-dominant. There is a high OM. The OM in the proximal segment shows 80% stenosis, and then this is the aleocranial view. In aleocranial view, we can see LAD 100% stenosis with distally diffuse disease in the proximal segment. The RCA was dominant vessel and 100% stenosis at the proximal segment. Then in attempt to cannulate the graft, for right-sided coronaries, the catheter we used was JR4, and with slight gentle withdrawal with the counterclockwise rotation, we tried to look for right coronary grafts, but right coronary grafts could not be found. We also took the cuspal shoot, as usually the right coronary grafts are behind and above the right coronary ostium, but we could not locate the graft. We could not find it. Then we took the Riemann shoot by counterclockwise rotation and slight gentle pullback of the JR4 catheter. We can see the opacification of the Riemann. The Riemann appears to be normal. Then we then to locate the left Lima graft, we first cannulated the left subclavian artery, and as we can see, the opacification could not delineate the native coronary vessel, so we attempted to cannulate the left internal mammary artery by using Terimo guide wire. We can see the graft appears to be patent. The Lima graft, two diagonal one, the Lima graft to LAD distal LAD part. We can see the graft segment appears to be healthy. The distal anastomotic site appears to be normal. The SVG, two diagonal. The proximal and distal anastomotic site appears to be normal with minimal plaques in the mid segment. Then we will come to case number 2. Case number 2, 60-year-old male, the known case of type 2 diabetes mellitus, hypertension, and with a past history of CABG in 2012, 2 grafts, SVG to OM1 and Lima to LAD, with PTCA to LAD done in 2018. Presented with complaints of sudden onset chest pain since 1 day and associated with profuse fatigue. On general physical examination, patient relevant finding was patient was anxious, pulse was 108 beats per minute, regular good volume, blood pressure 156 by 90 millimeter of mercury, respiratory rate 24 cycles per minute, saturation was normal, JVP was not elevated. Systemic examination, CVS S1 S2 was normal, no S3 S4, no murmur, no abnormal heart sound. Respiratory system, core abdomen and CNS was normal. On investigation, CPKMB was 108 units per liter, HS troponin T was 544, and other blood investigations were within normal range. His ECG was done. ECG was suggestive of old anterior wall MI, QS in V1 to V3, and poor RV progression. 2D echo was done. Parasternal long axis, parasternal short axis view. Here we can see the hypokinesia of anterior, anteroseptal, and anterolateral segment. And in apical fourth chamber also we can see the LAD territory involvement. The coronary angiography was done. This is the RAO cranial view. We can see LAD. In LAD, we can see the mid LAD segment is 75% instant restenosis is there. With we can also see the retrograde flow to the right coronary. LCX. The LCX appears to be diffusely diseased from the distal part. Right coronary was dominant with 100% stenosis in the proximal segment. Then we attempted to cannulate left coronary grafts by using JR4 catheter. We can see the saphenous vein graft to OM branch, the proximal and the distal segment. In this view, we can see distal segment. The proximal and the distal anastomotic site appears to be normal, and the graft segment appears to be normal. Rima shoot was taken. Rima was normal. We can see here Lima. Lima appears to be 100% occluded, as we can see the stump over here of Lima. So points learned was the details of graft procurement should be obtained beforehand. Cannulation of graft should be performed gently using the correct methods, and use of other catheters to be done. And before going for CABG, complete assessment of Lima with respect to its size, tortuosity, and kinking to be done. Thank you.
Yeah, Dr. Akshay, you can hold on to the screen for a second. Are there any quick questions from any attendees as on now? Otherwise, we'll proceed to the lectures. I understand this is a recorded meeting, but will there be any questions? Technical team, are there any questions which we need to take right now on the two cases presentation? Yeah, the technical team, please. Okay, we can go ahead with the second talk. And let's go ahead with the second.
The slides are visible.
Yes.
Very good afternoon. Thank you, CSI, Dr. Dayasagar Rao, Dr. Uday Jadhav, sir, for giving me the opportunity to speak on the topic of post-CABG graft evaluation by angiography. What are the indications of angiography in post-CABG patients? It will be symptomatic patients with angina, angina equivalent dyspnea, asymptomatic patients with large area of ischemia, new onset LV dysfunction or congestive heart failure, and new ECG changes. In these cases, we need to do an angiography. What are the aims of our angiography? We need to see the native coronary artery disease. We need to see the graft patency. We need to see REMA and LEMA for arterial grafts, and venous grafts. We need to see the SVG to PDA, OM or diagonal. We also need to assess the proximal and distal anastomotic sites and their patencies. We have to see the length and the size of the vessels with the disease, native or graft, because we are also thinking of whether can we revascularize these vessels. So how do we do an angiography? We have already seen a few clips. Angiography, graft angiography, to engage the RCA, right coronary graft, SVG graft, we need to almost pull out the Judkins right catheter a little bit and rotate it slightly anti-clockwise to engage the graft to the RCA. There are some rules of angiography in post-CABG patients. We have to start with the native vessels always. Most of the vein grafts will be located in the projection between the second and fourth sternal sutures. The ostia of the grafts usually will be close to the surgical clips. Grafts to the RCA are best engaged in LAO 45 and to the left coronary are best engaged in RAO 30. Sometimes the obtuse marginal grafts are located posteriorly and we may need an AL catheter to engage them. And once we have cannulated the graft, we have to use LAO RAO projections and also look for various other projections to look at the disease in the distal anastomotic size or into the native coronary arteries. So this is one of the angio which we did in a patient, and we can see that this is one of the SVG graft to the LAD, and we can see there is some lesion in the proximal segment. But this was not exactly a lesion, because when we did the next shoot, we came to know that this was just a spasm which had occurred in this SVG. So we just had to give the patient little bit of NTG, Nicoran, and we had to slightly disengage the catheter because we had probably deep throated the catheter. So there are some rules of surgical placement of grafts. The SVG to PDA grafts is the most inferiorly located graft on the aorta, and it is usually on the right side, just above the right coronary artery. The second graft is usually to the LAD. It is located on the anterior aspect of the aorta. The third graft is mostly to the diagonal if it is done, and it is located slightly above the LAD graft. And the fourth graft is little bit lateral, left, and maybe posterior sometimes, which may be to the OM. There are a few studies which I like to quote. The L-Record study, which came in Journal of American College of Cardiology in 2020, says that cannulation through the left transradial approach is non-inferior to transfemoral strategy for CAG in patients with post-bypass. So they show that in radial angiographies for post-bypass patients, the net procedure time is little less. The contrast used for radial angiography is little less, but fluoroscopy time and radiation exposure is almost the same in femoral and radial approaches. So this is one of the patients we did SVG, which is showing angiography of the SVG graft to the RCA, and which seems to be patent. This was done through the left transradial approach. This is the same patient showing LEMA to LAD, which is a patent graft, and which was again done to the left radial approach. So LEMA is the choice of graft to LAD coronary artery. Unlike saphenous vein grafts, LEMA grafts rarely develop atherosclerosis. They have reported only in 4% of cases, and only in 1% they develop important atherosclerotic luminal narrowing. An important factor affecting the early arterial graft patency is native coronary artery blood flow. When performed CABG to hemodynamically unimportant or moderately stenotic LAD vessels or lesions due to overassessment of LAD lesion, this may lead to competitive flow between the native LAD and the LEMA graft, resulting in anatomically or functionally LEMA occlusion or reverse flow. So this is one of the patient we did post-bypass, we did an angio. We can clearly see the retrograde flow into the graft, venous graft. This is from the RCA, and we can see the retrograde flow into the RCA graft. So this kind of grafts are likely to close early. There could be a graft occlusion. Then if we think of revascularization, we have to understand some factors favor bypass, redo bypass, and some factors favor PCI. So what are the factors which favor bypass? Are availability of internal mammary artery grafts for LAD grafting, the ability to provide left main revascularization, recurrent restenosis of the stents, antiplatelet defaulters if the patient is not taking treatment properly. There is no use doing a redo PCI in this patient. High complexity of the PCI procedure. There may be very few functional grafts left. So bypass, if IM graft is available, is a choice. If it is a CTO lesion, they say the bypass is better, redo bypass. And also for patients with lower LV ejection fraction, CABG is preferred over PCI. In patients with patent graft, that is Lima to LAD, PCI is favored. In patients with amenable anatomy, PCI is favored. In patient factors, sometimes the patient do not want to undergo a PCI, or sometimes they have comorbid conditions. We cannot do a PCI in such cases. We cannot do a CABG in such cases. PCI is preferred. So 2021 ACC AHA guidelines have given very good information regarding the treatment of these post-bypass patients. In patients with previous CABG who require PCI, 2/3 of these procedures were performed in native coronary arteries instead of bypass graft. They say that when the PCI is done in a native arteries, it is more long-lasting compared to the graft PCI. So in another study of large prospective registry, they found that prior CABG who underwent SVG PCI had higher rates of cardiac death, stent thrombosis, ischemia, driven target vessel revascularization, and overall MACE at 2 years. So the guidelines say that in patients with previous CABG with patent Lima to LAD who need repeat revascularization, PCI is feasible. It is reasonable to do PCI. This is a class 2A indication. In this, previous CABG and refractory angina on guideline-directed medical therapy, it is attributable to LAD disease. It is reasonable to choose CABG over PCI when internal mammary artery graft can be used as a conduit to LAD. And class 2B indication says that previous CABG and complex coronary artery disease, it may be reasonable to choose bypass over PCI when IM grafts can be used as conduit to LAD. So they have found that why there is a graft patency is lost, or why there is a graft closure, graft disease. Sometimes they have made a study in which they have seen that microvesicles in the patient from the platelet activated platelets can predict. They can be an independent predictor of mid-term graft occlusion in CABG patients. So they showed that if we have done the microvesicle levels and from the activated platelets, if they are low prior to the CABG, then only aspirin can be given to these patients post CABG. But if activated platelets and microvesicle levels are higher in these patients who are going to undergo CABG, we have to give double antiplatelet therapy in these patients because there is a high chance of graft occlusion. So there's another study which shows that only angiographically, which is the best angiographic predictor of graft patency, they have said that chronic collateralized total CTO artery of the LAD, total coronary occlusion of the artery other than LAD, they have shown that all grafts anastomose distally to the chronic total occlusion LAD remain patent. So 100% patency in a LAD, which is a CTO 100% occluded. They have shown, one study shows that off-pump and on-pump, if they have studied that Lima grafts, LAD to Lima and saphenous vein graft, they have shown that they are comparable. The graft patency is comparable in both of them. Then this is one patient. We'll present few cases in which we can see the 70-year-old gentleman, known case of diabetes, hypertension, status post CABG 12 years ago, who presented with angina, had stopped antiplatelets. And his ECG showed old inferior wall MI, cardiac biomarkers were elevated, LVEF was 30% and showed inferior wall MI. So we can see 100% occlusion of the LCX and also the LAD. LAD is also 100% occluded in this patient. So there was a patent graft to Lima, so that was not a problem for LAD, but we could see that the SVG graft to the PD was having significant disease, about 95%. So we went ahead and we have put a stent across the SVG graft to Lima, to RCA. This is the second case. In this case, he's a 65-year-old gentleman with previous CAD, triple vessel disease, status post bypass in 2012, status post PTCA to LAD 2018, who presented with angina. And we could see in the angio that there was instant restenosis of the LAD stent. So EF was 30%, Lima to LAD was showing, this was the RCA, 100% occluded. This was the Lima graft, which was again 100% occluded. This was the SVG to LCX OM, which was patent. This was the Lima graft, which was 100% occluded. So we didn't have a choice. RCA was occluded, LCS was occluded, the Lima graft was occluded, and there was instant restenosis. So we had to again redo PCI and stent the LAD in the proximal segment to establish the flow in the LAD. This was the third case where this patient was a lady, 80 years old, post CABG, who presented with angina, and she had a patent Lima to LAD. She had a significant lesion in her RCA, proximal RCA, and SVG to her PD was closed. So we had to do a stenting in her proximal RCA. This is a fourth case. This is a 68-year-old gentleman, and we can see that the Lima to LAD graft is showing significant tortuosity. So this kind of grafts are amenable to occlusion, though in this case we can see a good flow to the LAD. In some cases, though the graft is working well, we see that the native coronaries have very severe disease and there is hardly any flow noticed in the native coronaries. In such case, either PCI or bypass won't work, and such cases will have to send for medical line of management. So what are the limitations of invasive coronary artery angiography? Though coronary angiography is gold standard of pre-procedural risk assessment when coronary artery disease is treated with catheter-based interventions, standard coronary angiography is only a luminogram that provides little insight into the plaque deposition and pathology. It cannot delineate the extraluminal calcium or the route of native coronary arteries or graft vessels. Or there could be access site issues. In such cases, CT coronary angiogram is the investigation of choice. So take-home messages from this presentation would be: details of the CABG graft must be procured before proceeding to angiographic graft evaluation. A heart team approach is essential to take decisions about revascularization in patients with post-CABG angina. Native vessel PTCA is preferred over graft vessel PTCA if Lima is patent, and the need for any repeat revascularization after PCI or CABG is itself an independent predictor of high mortality risk. Thank you.
Thank you, Dr. Shilpa. Thank you very much.
Thank you, sir.
I just see that's very well covered. I think the entire gambit of how we deal with graphs. So I just saw a message come through that this is a recorded meeting and it goes on the YouTube also later, the masterclass. So we will finish it at a go. If there are any questions we are supposed to take now, we'll be happy to do that. And the other thing is they have said that the questions can then be posed and can be sent to us on mail and we have to clarify them. We are okay. And there are already 225 residents who have joined. So that's very heartening. I'm very glad that has happened. Let me see if I can share the screen. You can stop sharing the screen and see if I can do something here.
Sure. I have stopped.
Yeah, thank you. So I'm going to start somewhere here. Are you able to see my screen before I go in?
Yes, yes.
Excellent. Okay. So I will show you now the other viewpoint and discuss with you how you take it forward on the cardiac CT coronary angiograms. I'll share you my entire experience of both technical and the processing of the last 17 or 18 years of how we do it. And so CT coronary angiogram is in fact excellent for CABG from multiple viewpoints, right? One, it's easy to see the graphs. Second is that on the volumetric imaging 3D, as you start, you get a perfect way of how the graphs are placed. Thirdly, is that lot of limitations which were there, let's say when I started 15 years back or whatever, I could see concerns of contrast, radiation, the field of vision extending through the city. The current generations of 120th slices have been able to overcome everything, absolutely everything. So I'll make comments on that. Now you see one of these city graphs. So Dr. Akshay had wonderful cases both, and so Dr. Shilpa Kadam showed some great cases of vasospasm and the graphs. But the first case where they were not able to see whether the SVG graphs actually were there. So here is a SVG graph, if you can see in the two green arrows. You can see those bumps there, right? So the first second have gone good, but the third the first second have not gone good, and the third SVG graph is okay. So you simply see the SVG bumps there, and I'll show you some great images. So here is typically how a SVG graft occluded looks. On the aorta, you will see, this is called as the Newbin sign. You will see two small buds or nipples on the aorta in the cross section at the upper part. And you can also see, fortunately, the ghost shadow of the SVG. From where it emerges after the bud, you can see the shadow of this particular graft. Okay. So classically, here is how does the volumetric Lima LED graph looks at. Let me show you a couple of images if I can, or let me start with this only and tell you a couple of technical things. So what happens when we do the cardiac CT is for the arterial graphs, and which are generally Lima LED is always used, we start the scanning from the clavicle down, and we go to the base of the heart. So exactly this is the territory which we scan. The amount of radiation is almost the same with the current generation of machines. So we use 100 to 120 kVs, 350 milliamperes, that's good, 350 mass. And the breath hold is a little longer, but that has got shortened now. So previously we needed 15 to 20 seconds of holding the breath. Now you can do it in 12. Generally, graphs require 12 to 20. That's my experience of every new graphs that we do. There has been a little difference in terms of how we scan to reduce the radiation. We have brought down the radiation now in the current techniques by close to 70%. I was a part of the Protection 6 study, and you can go through the net, and it was published in the Journal of ACC Imaging also, which was a German-initiated entire global study. And what we do is, though we scan from the infraclavicle region as you go to the heart, the trigger is still kept in the descending aorta at the coronaries, so that you can see the graft at the origin, and as it goes down, what is most important, where does it get linked to the anastomosis and how the distal flow looks. So this really works well if your trigger is kept where the coronaries are, but you can scan the entire heart. Make sure that the sternum is well covered, both in the anterior and in the lateral view. Why is this important? Because CT gives you many more information than the angio does. It looks at many other things. How the sternal clips are, whether there is a wound dehiscence, important, whether there is underlying mediastinitis after the CABG, whether there is a collection there is a hematoma there. You can look at the pleural spaces. So make sure that in the lateral view, the sternum is well covered. Otherwise, you miss a very important piece of information there. As the graphs go down, you need to scan a longer portion of the heart, right? Normally, if you look at coronaries, and like in cardiac MRI we do, you can do it in 4 to 6 centimeters. Here, you'll have to go 12 to 20 centimeters. So it's twice. So the breath hold is a little longer. Previous contrast use, this is the advantage of the graphs on CT angio versus the conventional angio. See, as Dr. Akshay was presenting, there is sometimes a difficulty in hooking the graphs, even localizing, particularly if you don't have a surgical notes information available with you pre-graphs. And that's something you would never want to do, both in the usual CATs as well as in CT. You must need the surgical notes. So here the advantage is that the amount of contrast that we use for this used to be 120 ml in the past. I have never done that over the last 2 or 3 years. Most of the time, you can add 10 ml to extra to what you have been doing. So 70 to 80 ml. Mostly we are able to do it at 80 ml. Unless it's an obese patient, multiple graphs, then 90 ml. Don't give too much contrast because it plasters all over. And with the metallic artifacts, you will see too much of a contrast around to make sure how the anastomosis are looking. So stick to the same contrast amount. The radiation is curtailed. Breath hold is 12 to 20 millisecond. Ask the patient to hold the breath properly by instruction. Beta blockers very important. You need to see the graph in all phases. So just oral metoprolol half an hour before, and you can go through and see all the graphs very, very well. And I will show you now the picture. So that's the technical part, that you will use much less contrast and you can see the graphs very well. So here is a Lima LED graph on the CT. Now, I always feel, and I always demonstrate this way when I go for meetings or in workshops, take it segment by segment. Cardiac CT, you have to pay attention. It's not that it's just one go and you report whatever you want. Here is the Lima LED graph, right? And you see those multiple clips and everything. Now, if you don't see the anastomosis of Lima LED graph so well down, you see it in another segment. But principally what I wanted to bring to your focus is, here is a left radial used to graph the OM1. And you can see very well the OM1 flowing here. And then an attempt has been made from here to go down up to the PDA PLV. These graphs are tedious. So always rotate the heart around and see, because this will be at the back. And these are a challenge for all cardiac surgeons, if you believe me, because you see, grafting the LED is technically simple. Grafting the circ takes a little more skills, because you need to go posterior, right? And you need to go to the PDA PLV. And that's where the anastomosis is not as perfect. So see, you see the radial artery linked to further the PDA PLV after the OM1, and you only see the clips. There is no flow there at all. That's a closed graph, all right? You see that in diastole, you see that in systole, and make sure that's how it is happening. And then you turn the heart around and look there. On the left side, as you go through the circumflex area, right? Here is that graph. Nothing. There is no vessel here, right? So the PDA PLV has now remained unprotected. This graph fails the most often. Here is a Lima LED graph. Now, when we do the CT coronary angio for bypass, there is an advantage. When you look at the anastomosis, sometimes on smaller vessels like D1, it's a challenge. But here, you can see a very good diagonal flowing with the Lima D1. Sometimes this is a matter of concern because it's small. Very nicely seen on the coronal view, a very good Lima LED graph hooked down, and you see the entire vessel very well, right? And here is the Lima LED graph flowing so very well. You can see the entire graph. You can also see the site of the anastomosis. Now, very important, I made that point with Dr. Akshay also. It's not just the anastomosis. We need to be careful and we need to be sure about it, because that's what the surgeons are most concerned. But most of your cases of angina will be the distal vessel, the circulation distal. And believe me, that's a challenge for us on cardiac CT. Why? Some of these vessels are so thinned out. And with the lesser spatial resolution that you get on a CT versus cath for any vessel evaluation, the smaller the vessel becomes, and that's what is expected in the distal LED, sometimes 2 millimeters, 1.5 millimeters, to comment on a disease becomes difficult. So that's where it matters for everything, the breath hold and how well you have planned the graft. So let me show you some of these things. Here is the Lima LAD anastomosis, right? You see the Y very well there and the anastomosis perfect. Here is the distal LAD after the anastomosis. So you see the four clips up. The four clips up are the metal and you see the distal LAD. Now, these sort of picture you should get to convince a cardiologist or a cardiac surgeon that he has done a good job. If you look at the first CAG, we were not very sure how the distal LAD looked after the Lima got anastomosis. It should look like this. The LAD distal should flow perfectly well after the anastomosis has been done. Okay. Again, a LAD distal. This is the OM1 anastomosis. I'm just showing you the pictures and I'll make a few comments before finishing. And here is that occluded radial to OM graft, just the metal clips, nothing else, absolutely nothing else. Here is the native part of the RCA Lima, and I'm going to come back to this. I've shown you these images of the occluded RCA PDA, but let me come to some other things. I mean, they are important. This patient also had stents in, and the stents had a mild to moderate in-stent rhinostenosis. It wasn't very significant because this patient had another problem, so we looked at it. Let me come to something interesting. That on the CT, besides all these things that we do, there is one important thing to be looked at. Here are the CT images, volumetric, is this. When you see a graft, mind you, some of these patients, as Dr. Akshay showed in both the cases, also have a CTO. It is important to diagnose acute occlusion versus a CTO in patients who have got multiple things. They have angio done, they have angioplasty done, they have a bypass done, and they've come with angina, and you don't know what's acutely occluded also, particularly if it's a recent onset angina with extremely high troponin, like the case Dr. Akshay showed, where the troponin jumped up 4-5-fold, went beyond 2000. Few important parameters on CT that are really, really helpful. Number one, for CT, look at if you see in that image multiple calcifications. That's a great indicator of CTO. In the segment where the artery is occluded, if you just see white spots of calcium and nothing else, that's short CTO. Second, if the length, the segment length of the disease segment is more than 9 millimeters, very high chances on CT it will be a CTO, extremely good sensitive marker. 3, that's true for cath also. Just look at whether it's tapering or just a blunt cutoff. The blunt cutoff is extremely useful. 4, the bend between the two arteries, the proximal and where the CTO starts. If you get an angle, and wider the angle, worse it is. 45 degrees and beyond, worse it is. That's a very good marker. 5th is something which we have to remember. CT is not a flowing angiogram. It doesn't have the same spatial resolution. Never comment on, I see that happening with a lot of radiologists also. Never comment on the patency of a stent or a graft based on what is seen distal to that stent or the graft, because your cardiac cycle has changed 1 and 2, and therefore you can have a feeling quickly retrospectively or retrogradely, and you will see the distal flow. The only point I pay attention is to the immediate area where the stent has ended or the graft has ended. If you see, at least for CABG, a good contrast there, mostly you will not see the trouble. So this is called as the CT rector score. This score is very important. If you see this on the CT of the multiple occlusions, blunt stub, severe calcification, and bending, the duration of the CTO, it has to be more than 12 months. And then you put the score together, it is a predictor of how well you will do when you put a stent or whatever approach you want to do for a CTO. Why I've included these particular slides are because they are a part of the CABG evaluation. Let me complete this discussion by making a couple of relevant comments when it comes to post-CABG. The venous grafts are notorious to get occluded. The venous grafts are large, so very well visualized. You generally don't miss them on CT. Generally, we never miss them. The vessel size there is 5 to 10, right? Unless the native arterial, which is like 2 to 4 millimeters. So the larger size in terms of millimeter allows you excellent evaluation of venous graft. The venous graft are prone to intimal hyperplasia, as you can see in the first case of the SVG graft. And they are very prone to atherosclerotic vessel wall pressure changes. And therefore, very common for SVG grafts to get occluded. The Lima graft, as we know, is excellent and it stays put for a long period because there is an absence of fenestration in the intima, in the elastic laminae, and therefore they stay where they are. And secondly, there is a lack of vasa vasorum. These two factors, unlike all other big vessels, allows Lima to remain patent. So that's why we call it as the lifeline. I haven't seen many cases of Lima getting occluded, as Dr. Akshay showed in the in the second case. And in Europe, in order to reduce the radiation, I'm a member of the European Association of CV Imaging and also for the Cardiac Society fellow and the SCMR also. In Europe, they believe that the Lima anastomosis does not get occluded. So they do not start from below the clavicle. They start from the aorta because they have never seen that. So, I mean, their experience is that it just never happens. It's very minuscule. And therefore they feel if you can just see the coronaries, the distal part of the grafts and the anastomosis and distal flow, like in any CT coronary angiogram, so radiation quickly goes down. Breath hold is nothing. But now we have the Aquilon 320 and you have the Siemens Flash, which takes one heartbeat. Nothing is required. You don't need a breath hold. You don't need the scan time. You don't need the length. So I think that will be the answer to all this. But after this case, I have learned from Dr. Akshay, I think I'm okay doing it from below the clavicle and seeing it all over. Though I have yet to see Dr. Akshay a single case, in my experience, of an occluded Lima right from the start on a cardiac CT. Maybe on cath we may be seeing that more. We do not know. The Lima has as I saw, a little sort of, nip on there, and then you don't see anything. Interestingly, we don't see anything distally also. There are hardly any there are no metal clips, and there are no distal anastomosis. So if you are in the cath lab with Dr. Akshay, some of your residents, and you have to see this coronary angiography, you will have a tough time because you don't know what's going on with this patient. What have the surgeons done in the first place? So this is also an example for us that there is no need to keep heroics and play a cowboy, a sort of, Texas cowboy attitude. We need the surgical notes. They are very important. So there are times when you will see the pagettes, the fillet pagettes on the aorta. These are sort of metal clips. They are very important to see. When you do a scan, they will be hyper intense white. Why are they required? Because if you haven't paid the attention and the contrast has gone in, they will exactly look like a contrast leak. Now, mind you, like distal, in the early CABG evaluation, the proximal anastomosis also can have a leak. And that will look like a white patch of opacity, right? Just like you get that puff when you create a dissection or in mitral regurg or in aortic regurg, or when you inject the contrast and it comes out of the cusp in cath. Exactly like this, you will see that little smoke, and that white smoke will only appear on contrast. If it is a leak on the plain scan, it won't be there. So if it's plain scan white, contrast white, then those are the pagettes. Those are those small metal things, bullet-like, which the surgeons implant on the aorta when they want to pack the graft properly. These are important things. So graft CABG evaluation on CTCA is not just the grafts. Everything. You want to give as much possible answer to the surgeon particularly if it's an early CABG phase. In the later CABG phase, the cardiologists are more interested because they would want to know that in a patient of angina, as Dr. Akshay demonstrated in both the cases, you need more and more information. Thank you, the entire MGM team, and Professor Dr. Shilpa Kadam and Dr. Akshay. Brian is in a case, he just called me. So thank you. If there are any questions, we will take now. Otherwise, it goes on recording. We are very happy to come back anytime. Let me stop and sharing the screen. Yeah. The technical team, please. Is there anything for us before we leave? So thank you, Dr. Shilpa Kadam. Your comments and we close. Unmute.
Thank you, Dr. Uday Jadhav, sir. Thank you to CSI. Thank you, Dr. Dayasagar Rao, for the opportunity to talk in this masterclass. And I think we can sign out if there are no more questions from anyone.
Thank you. We'll keep the recording for us also. Thank you.
Thank you.